Good morning, good morning, everyone. It's good to see so many of you here. I'm Lucy Blok, and I'm working for the KIPS Tropical Institute in Amsterdam.
I'm Eric Hadsner, and I'm with the U.S. Centers for Disease Control.
And we are both chairing this very interesting session.
Can you please speak up? We can't hear you.
You can't hear? Okay, so we don't have. So okay, we have to speak up. We'll try. I don't have to tell you the latest report of the global report on TB is very clear. There is 1.8 million people dead last year on TB. More than 4 million people are not diagnosed and not treated properly. That's one of the reasons for this high death rate. And given all the efforts that are already going on, it means that things have to be done differently. So today, this session, we will concentrate on what we can do for some populations that we know are at risk of TB and usually have challenges in accessing care. And these are people in prisons, people living in urban slums, and homeless people. So I don't want to take too much time because we have some very nice presentations, I think, and I want us to get to hear that. So I also want to remind the speakers to really stick to the 8 minutes that we have asked you to do, because otherwise the last presenters cannot present, and that would not be fair, because all the presentations have their own very particular value and contribution to the discussion. So 8 minutes presentation, then we have time like 4 minutes for some discussion after each speaker. So I would like to call up our first speaker. Is that Dr. Roosra from Namibia? If you're not Dr. Roosra, but a replacement, please introduce yourself. You have to speak up really, because as you see, you have to be able to let the others also hear.
Yes, my name is Toini Awala. I'm the Deputy Commissioner. I'm working for the Namibian Correctional Service, and it's responsible for the nursing services.
So the presentation is on, so please go ahead.
Yes, I'm going to present to you the role of mass screening in uncovering outbreaks of TB in correctional settings. We are going to look at the outline, when we are going to discuss about the background, objectives, interventions, results, and lastly, conclusions and recommendations. The background: Namibia is a southern African country with a population of 2.1. It has a TB incidence of 561 per 100,000. And in 2015, the notified cases of TB were 9,944, and among that total is 18 cases from the correctional facilities. We have 13.5% HIV prevalence in 2015, and we have 13 correctional facilities and 1 training college in the whole country. The total population of inmates in 2015 was 3,343. Including 89 female inmates. Our objectives are to identify inmates and staff with symptoms compatible with TB and perform necessary diagnostic investigations. The interventions: Namibian Correctional Service is not working in isolation. We are being assisted by the Ministry of Health and Social Services, so we adopted a screening tool from the Namibian TB guidelines to conduct a screening. And we targeted both staff and inmates. Questions that we asked to participants mainly focused on the key questions related to TB. And at the same time, the participants were also asked whether they know their HIV status. Those who were found with TB symptoms, sputums were collected for smear microscopy and expert NTB. The results from this mass screening, 12 correctional facilities participated in this campaign, and 909 inmates were screened out of 3,343, and 410 officers were also screened from a total number of 2,189. There were some who were found with symptoms. Offenders were 265 and staff were 66. 262 inmates submitted sputums, while 66 staff did the same. Among these who were tested, 4 were tested positive, and during that time, and 2 were from the staff, while 3 were from the inmates, and all these were all from the one correctional facility. This correctional facility, 16 staff is where we got the 2 who tested positive, while from 114, 3 inmates tested positive. So it means that we have 12,504 for the staff, while 2,632 per 100,000 inmates. That's the prevalence. That table is just a duplication of what I have explained earlier in the previous slide. So I don't need to discuss that, because I have already done. In conclusion, I would like to say that when we conducted the TB, this mass TB screening, we uncovered an outbreak of TB in one of the correctional facilities, and TB does not discriminate. It affects both staff and offenders, and we recommended that routine TB screening should be ongoing and maintained in all correctional facilities, and that there is a need to address sensitization and stigma reduction to increase uptake of screening. That photo is a joint training that was conducted by the Ministry of Health and Social Services, trained our officers and the police to be ready for this TB mass screening. And I think I've come to the end of my presentation. Those are just the acknowledgement that we thank the Commissioner General of the Namibian Correctional Service, the Ministry of Health and Social Services, specifically the Directorate of Special Programs, USAID through KNCV TB Foundation, and the Namibian Institute of Pathology. I thank you.
Thank you very, very much. Good and clear presentation and staying within the time. There is time and room for questions. Can I invite people, if you want to, you can say who you are and speak loudly. First there, and then I'll come to you.
I am Falak, I'm from Pakistan. I have was wondering, you showed a slide about the percentage of people screened, and not all of the prison inmates were covered in that screening. Was that a consent issue or another reason why they couldn't be screened?
It was not a mandatory, so some they opted to, but who refused, we cannot force them. But for one correctional facility which was not included there, it does not mean that it was not done, but the report is not included because it was done at a later stage.
Okay, so this is not the data of all the inmates, if I understand.
No,
Of
it's
all
not.
all the screening.
No. The 13th correctional facility, it was not done at the same time with the rest. That's why it was not included.
That satisfies your question. I would like to actually still maybe continue a little bit more on it, because you said, well, okay, it's consent, so if they don't want, they don't want. But what are the challenges? Why? I mean, because it's a low percentage, just about 25%, while you would feel that it would be greater if you could do more than that and get closer to 100%. So what were the main challenges in not achieving that?
I think the main challenges that we are facing is the lack of understanding. The campaign to make them understand, it played a major role, because some of even the correctional officers, the majority of them, they were not coming forth to be tested. So as a result, they influenced offenders not to be tested as well.
Another question
Yeah,
there?
I had the same question, but I can ask another one. My name is Christian Mulder. I'm from the Netherlands. Thank you very much. I was wondering about the TB symptoms. What were the most prevalent TB symptoms?
The TB symptoms were mainly cough for more than 2 weeks. Have you swelling of the lymph nodes? Are you sweating at night? Have you lost weight recently or for no apparent reason? So those are some of the questions that we ask.
So I think he's asking, of those symptoms that you asked, which was the most common response?
Coughing was the most common.
Yeah, I see another question there.
I'm Ella from Netherlands. Thank you for a wonderful presentation. I'm just wondering whether currently you have any mandatory screening projects in the prisons. I mean, after the project, in terms of sustainability, are you working on to have a mandatory screening in the penitentiary sector in general?
We have, during the admission, when offenders come to correctional facility, they are screened within 48 hours. And we made it mandatory to be screened even during their stay and before they are released. And on top of that, we have introduced a TB mass screening that covers both inmates and staff to be conducted twice a year.
One more question, and then I think we have to close this part.
Bill Coggin, CDC. Was there any contact investigation done around these cases detected, given this was a congregate setting?
Sorry?
Can you repeat?
Was there any contact investigation done around the cases that you detected, given that it was a crowded congregate setting?
And then when you say contact investigation to within the prison or also with people outside?
The prison for the inmates and the families of the guards, etc.
Since the screening covered both, when I talk about the correctional staff, I mean all that are working in the correctional environment, as well as offenders that are living together with those who were tested positive.
But you did not go beyond that.
We did not go beyond to go to the families of the offenders.
So, yeah, we have to move on, I think.
Sorry, we have to move on to our.
I'm sure that after the session, presenters are still around and you can further discuss. Thank you very much.
Yeah, do you want to sit here or stand?
Standing is
Okay.
better. Are you okay standing?
Okay, no problem.
Okay.
Yeah?
All right, I'd like to introduce Dr. Kyung-Yun Oh, who will be presenting on yield of systematic screening for tuberculosis among vulnerable populations using enhanced diagnostic tools and algorithms in Palawan, the Philippines.
Yeah, thank you. My name is Kyung-Yun Oh from the Korean Institute of Tuberculosis, where I'm in charge of the program cooperation, including the public health research and domestic and international cooperation. And so today I'm going to talk about the yield of the systematic screening for TB among the vulnerable population in Palawan, the Philippines. This is the result of this activity project. As you know, the systematic screening among the high-risk groups is a component of the NDP strategy pillar 1, and according to the WHO guidelines, PHIV and close contact and the people exposed to silica is strongly recommended. And the prisoners, migrants, and urban poor and indigenous population, etc., are conditionally recommended for the systematic screening. DTAC TB is the intensified case finding project in Palawan, the Philippines since 2012, and which is funded by Korean International Healthcare (KOFI), implemented by KOFI, DOH Philippines, WHO Philippines, Korean Institute of Tuberculosis (KIT), and local governments. The objective of the study was to describe the yield of TB screening and treatment outcomes by different target populations in DTAC TB. When it comes to the programmatic information, we use the mobile unit equipped with the digital X-ray machines and gene expert and LED-FM. And as for the diagnostic algorithms, we screened all participants by the symptom screening and chest X-ray, and consequently identified the people to be evaluated for TB by the cough for more than 2 weeks, or the active or actively undetermined TB lesions on chest X-ray. And we diagnosed the TB, the patients, by the LED-FM and the expert among the people to be evaluated for TB. We target the prisoners, urban poor, rural poor, and indigenous populations, high school students, and etc. And this figure shows the diagnostic procedure algorithm. Anyway, I mentioned already. And after diagnosing TB patients, we refer to the DOTS facility or PMD facility according to the result expert. And the study was the retrospective review of the screen data. And between the December 2012 and August 2015, we included the prisoners, indigenous population, urban poor, and rural poor for the target group, excluding the high school students, which showed a very low yield. This table shows the characteristics of participants. We totally screened the 22,000. And more than half of them were just rural poor, and the prisoners were the 6,000, and indigenous populations were the 2,000, and the urban poor was the 1,600. And among the prisoners, male is the very dominant, and on the other hand, among the other groups, the female is dominant, and prisoners and urban poor are younger than the indigenous populations, the rural poor. Next. This table shows the screening result. Okay, briefly speaking, among the prisoners and the urban poor, the more asymptomatics are more common among the indigenous populations and the rural poor. On the other hand, the abnormality of chest X-ray is higher among the prisoners and the urban poor. And this table shows the sputum test result, and the proportion of the smear positivity is higher among the prisoners and the urban poor. Next. Okay, in conclusion, we diagnosed 759 patients, which is the 3.3% of all participants. Very huge prevalence. We calculated the NNS, and then each group, every group showed the less than 50, which means the prevalence is more than 2%. For each group, yeah. So every group have shown. Next. And this figure shows the composition of bacteriologically confirmed TB by smear and symptoms, and just the deep red means the smear positive and symptom positive, and the light red means smear positive and symptom negative, and deep blue means smear negative and symptom positive, and the light blue means smear negative and symptom positive among the bacteriologically confirmed TB. And as you can see, just the red color is more common among the indigenous population and the rural poor, and the deep color is more common among red color. Red color is more common among the prisoners and the urban poor, and deep color is more common among indigenous populations and the rural poor. Okay, this table shows treatment outcomes, and among the rifampicin susceptible TB, the TSR was the 89.5%, and among the rifampicin resistant TB, the TSR was the 83.3%. Both are very successful. Okay, our study showed a substantial yield through the project and large contribution of combined use of chest X-ray and expert. And the order of NNS from the lowest and to the highest is the prisoners, the IPs, and rural poor, and urban poor. And for your information, the prisoners were just systematically screened, almost all participated in screening. While the screening was based on the voluntary population among the other groups. And we identified more symptomatic people to be evaluated for TB among the rural poor and the IPs, which might mean there is the poor access to healthcare in the rural setting. On the other hand, we identified a higher proportion of smear positivity among the urban poor and the prisoners in the urban setting. And we suspect that diagnosis delay or the multiple risk factors such as the smoking and the drinking can be contributed to the higher proportion of smear positivity in the urban setting. And we also identified a higher rate of lost follow-up among the rural poor and IPA, which also means that there's the poor access to healthcare in the rural setting. Okay, thank you.
We'll take questions on this presentation now. Yes.
I'm Catherine Stone from the University of Melbourne, Australia. With the prisoners, in the slide on the prevalence, you had about 380 diagnosed patients, and then in the slide on treatment, you had about 300. So what happened to the other 70 or 80 people? Were they not treated, or were they released, or what happened?
Maybe two reasons. There are two reasons. One is just they are not completing the treatment at the time of the analyzing, and the other one is just we didn't test the data.
Okay. So actually, possibly, it's a lot of loss to follow up. Yeah.
It's Karen from MBA. I was just wondering, how did you classify your poor group?
Okay.
And that's one question. The other one is you mentioned something in your discussion about the loss to follow-up in the rural poor. Can you share also with us what you do to address the issue of loss to follow-up?
Okay, good question. So the criteria for the rural poor and the urban poor is different. The one for the urban poor, just in the Philippines, there is some standard criteria for the defining the urban poor by income level. So maybe they are just designated as the urban poor by the income level, and so rural poor, we just operational. This is operational definition in the project. Just we define the rural poor as the area really showing the low case detection rate. Yeah. We just designate them as the rural poor.
Right, one other question for you. I was wondering, I may have missed the data. Do you have any data on how many additional cases you were able to detect with expert that were smear negative to see the additional yield of having expert excluded as part of this case finding?
In the full paper, we just analyzed the additional cases by the expert and X-ray. But anyway, just because of the time limit, I didn't include those data.
Do you have a sense of your recollection? Was it a substantial difference that?
Maybe the contribution of expert and X-ray is very substantial thing in those cases.
Okay, thank you very much.
Okay, then I would call up Dr. Hamim or somebody from Afghanistan to present for the case study from Afghanistan. Is there? Do we have it?
Yes.
But then, is there someone to present it? Or what is the next one that we have?
That's in there. Close it. It's showing up there, but it's not showing on our screen.
Technology.
Any particularly technologically savvy people that might understand when an arrow shows up on that screen and not on this one, how you might open another presentation here? Yes, sir.
I've a lot of experience with this. You generally try about turning it on and off again?
I think that would.
Is that before or after you throw it on the ground? Because it's always on the screen. It doesn't let me click.
Yeah, now you're here. So it's two screens next to each other. So now you're here.
Thank you.
So we do have the presentation. So yeah, I think we managed to. We didn't know that was two screens next to each other, so we couldn't get the mouse.
No worries, it's all on now.
Yes, please.
I think that's fine. But there is nobody from Afghanistan to present the Afghanistan presentation that we have nicely uploaded. But let's then first do, maybe someone comes in later. Let's just continue quickly. And then I would call up an, I don't know who's here from Bangladesh. Dr. Tawfiq, yes, you're right. And you will present for us the role of systematic screening in improving tuberculosis case detection in selected urban slums of Bangladesh. Please, the floor is yours.
Assalamu alaikum and good morning everyone. This is Tawfiq Rahman from Dhaka, Bangladesh. I work for ICDDLB there, and today on behalf of our group I will be sharing our experience with the systematic screening in improving the tuberculosis case detection in selected urban slums of Bangladesh. So according to a recent survey, it shows that around 60% of the total population in Dhaka city usually actually stays in urban slum areas, and the overcrowding as well as the living conditions there are creating situations for the slum dwellers to make them more vulnerable to tuberculosis, in developing tuberculosis, as well as it makes TB readily transmittable to one person to another. But there is very limited data on tuberculosis in the urban slums in Dhaka, and it shows in the national annual report, a recent annual report shows that only 13% of the case notification actually came from the urban areas, whereas we have around 40% of the total population compared to rural. And the slum dwellers also have poor access to DOT center because they have conflicting working hours and the DOT business hours, so they are in risk of wage loss. So sometimes they are actually don't show up in the DOT center when they have symptoms. And we believe that a large number of missed cases in our country, that which is currently 150,000 annually, can be found in those pockets, especially in the urban slum areas. So in this study, we actually had two objectives. One of them was to increase the TB case detection using the systematic screening in the slum dwellers, among the slum dwellers, and also we wanted to understand the TB transmission dynamics in the slum population through characterizing and classifying the prevailing isolates. And for the study, we actually selected slum areas. In one of the known slum areas, that is Nipur area, we have a very large slum area. So we selected that because they have very known actually high burden of TB was actually known there. And we conducted the study from January 13 to June 2014. That was 18 months period. So this slide actually summarizes the study algorithm in short. So our health worker at first mapped the slum area, and each household was visited at least once in a year. And we used a verbal symptomatic questionnaire to identify the presumptive TB cases. And in our case, we defined presumptive TB case for adults, those who are 15 years and above, who had cough for more than 2 weeks. And we also included another criteria, that those who had BMI less than 17, if they didn't have cough, we also actually define them as presumptive TB case. Because in another study from our group, we have found that this in risk group population, like that was in the prison population, we identified a large number of cases. They didn't have any cough but had low BMI. But for the children, we considered cough for 2 weeks as a presumptive TB case. So whenever we identify presumptive TB case, we ask for sputum submission, and sputums were carried to our laboratory for AFB microscopy and culture, and those who were AFB negative were tested with gene expert. And whenever we identified the bacteriologically positive case, we brought them under treatment, and MDR TB cases were also notified to the National TB Control Program for management. So these are few pictures of our field activities showing that our health workers working in the slum areas, they are mapping the households, and they are also asking the symptomatic questionnaires and measuring the height and weight of the presumptive TB cases. So over the 18 months period, we actually screened around 1,000 population in the slum areas, and we identified around 1,928 presumptive TB cases. So that includes both those have actually coughed more than 2 weeks, but a large number of them were low BMI. So we were able to collect sputum specimens from most of those who had cough, but we were unable to collect sputum who had not have any cough but had low BMI. So ultimately, we were able to collect 36% of specimens from those, and we tested through microscopy, gene expert, and culture. So 74%, that is large number of the patients were being identified using the AV microscopy. Gene expert added another 13% over the microscopy in detection. So in the period, we have identified a total of 134 TB cases, and 4 of them were also identified to have drug resistance, which is 4%. And considering the demographic distribution, we have found that the large number of cases were between the 15 to 54 years of age group, which is basically the reproductive age group. And nationally, we have found 78% in our study, but nationally the rate is around 66%. And we found that the male to female ratio was 1.1 to 1, and nationally our rate is 1.5 to 1. Maybe because as we actively searched the cases, the rate was kind of similar. So we also actually compared the data of baseline, so the previous 1.5 year and during the study period, and we have found that during the case study period, the detection rate went up by 12%. So as I had mentioned that we had another objective regarding the transmission analysis. So apart from those who were identified throughout the project, we also collected an additional 55 specimens, sputum specimens, those are positive, from the DOTS centers. Those were identified by the national program. So we included all in our study, and we were able to actually test 162 culture positive cases in that period, and we performed this polytyping as well as deletion analysis to see the transmission. And this is the map of the study area with the isolates in it. If you look into that, and there are a few colors into it, and the similar colors denotes that they have the similar strain of infection. So they are infected by the similar strain. So we have actually identified among the 162, we have identified 95 different strains, and 80 of them were clustered into 20 clusters. So we can say that there was transmission, though we have not identified any known epidemiological link except from one case. And you can see that if we consider the strain type, 53% was modern or epidemic strain, that actually represents active transmission, and another the remaining 47% was ancestral, that sometimes indicate that reactivation. And the largest cluster was from Beijing family, and among the MDR strains, we found that among the 5 MDR, 4 of them was modern strain. So in conclusion, we want to say that systematic screening in this kind of risk group population at least once a year can increase TB case detection in these pocket areas. And as you know that TB mycobacterium is a slow growing bacteria and incubation period is very long sometimes. So larger studies with long duration can help National TB Control Program in defining newer strategies. So I think thanks. I would like to thank the National TB Control Program and our partner NGOs that we work with. And this study was funded by USAID through the URC. Thank you.
Thank you. Thank you very much. The floor is open. Do you have a question?
Very much enjoyed it. Two things struck me about that that are quite novel, and just would welcome your thoughts on. And the idea of the accuracy of BMI as a screening tool seems to be quite interesting. But also perhaps what you've achieved in terms of the male-female ratio in terms of case detection. It strikes me, we seem to accept that there's a high proportion of males diagnosed with TB internationally, particularly in high-burden settings. It strikes me that an active case finding initiative in terms of the quality indicator should generate more equal proportion of cases across the sexes.
So for your first question, as I was mentioning that in prison, in one of our previous studies, we have found that if the patient has a very low BMI, so the risk is around more than 8 times to have TB. So that encourages us to include this kind of screening criteria as we were actually going home to home, and those are actually vulnerable population and most likely to have low BMIs. So we looked into that, and we have found around 5 cases, though that the number is not that much, but it includes some additional cases that would have been missed. And regarding the second question, yes, you are right, as we were actually going for active case finding that might have helped the females to express they have symptoms. Otherwise, due to some social barriers, they sometimes actually didn't show up in the health facilities to seek care.
Okay. And there.
Hi, Catherine Horton from LSHTM. If I could ask a follow-up on that. Your case distribution, the gender distribution was fairly even. I was curious about your screening population. Did you screen the same number of men and women, or did you screen a higher proportion of one to another?
Actually, the proportion was around 60% to 40%. 60% were male, 40% were female.
So more men were screened than women.
Okay. I see a hand just in the back there.
Andrew Medina from South Africa. So, of the 55 patients that were found by the clinics, how many of those were household contacts of any of the patients that you identified with your screening?
So, as I have mentioned that we looked into epidemiological links, so that includes household contacts, but except from one case, we didn't find any known link. So there was no household contacts on those 55. So those are individual patients from individual households.
I have a question for you. So you were screening at people's homes. For people that were symptomatic, were you actually collecting sputums right there at their home, or did they have to go to a facility?
No, we collect sputum from their home and bring there.
So what's your impression about why you were only able to test 36%? What was the barrier to not getting higher testing?
I have mentioned that, perhaps I can clarify. Because we included a large portion of patients who had low BMI, and they didn't have any cough. So they were unable to expectorate sputum. But those who had cough, we were able to collect more than 92% specimens.
Any last question?
Thank you very much. My name is Abbas Zezai from Namibia. In your background, you mentioned that there was limited access to care
poor access to care
because of rigid business hours for those. You did not talk about it further in the study. Is this something that you were going to mention, or You did not study.
Actually, I wanted to focus on that because why we wanted to have active screening. Because sometimes, usually we have the passive case finding strategies. If I have symptoms, I go and seek for health care. But sometimes in this vulnerable group, they are mainly daily wagers, and if they have to consider whether usually the DOTS hour is from 8 a.m. to 2 p.m. And it also coincides with their working hours somewhere else. So if they sometimes it can actually delay the health-seeking behavior, and if they choose to go to DOTS, they have to lose their daily wages. So that's the thing that we wanted, that active case finding can be helpful to minimize this.
Maybe flexibility to adjust.
I see still no hands, but I'm very sorry. I think I have to cut the discussion to also allow the next speakers to speak. Thank you very, very, very much. And I'm sure after this session you can call up Dr. Fikik for further questions.
All right, next we'd like to invite Stuart Chang to present on computational modeling of TB epidemiology in Nigerian urban slum environments.
Thank you. Good morning. I'd like to tell you about our attempts to model the epidemiology of TB in Nigerian urban slums. And I just want to preface by saying I'm not an epidemiologist, but a math modeler. This will be something a little bit different. So the first question we might ask is, why model urban slums in Nigeria? Well, as we've heard at this conference, Nigeria ranks fourth among high-burden countries and contributes about 6% of the global incidence annually. However, Nigeria also has the lowest case detection rate among the HBCs at around 15%. And so what we wanted to ask using modeling is whether addressing at-risk populations such as urban slums could help the epidemic. And this work is motivated by a couple of publications. First, the availability of a high-quality prevalence survey in Nigeria from 2012, and also a series of publications by our collaborator in Nigeria with KNCB, Chidubem Ogbudebi, on the urban slum situation in southeast Nigeria. So specific goals are one, to create a model of TB in Nigeria that includes urban and rural populations. Secondly, to show that the model can recapitulate some of the key results of the known epidemiology, mainly the prevalence survey. And also then, of course, to use it in some kind of functional way to predict the effect of interventions targeting the urban slums. Please. So just a brief word about the modeling software we use. It's called EMOD. It's developed in-house at the Institute for Disease Modeling in Seattle. And we use it to create dynamic simulations of epidemics. And so individuals in the software are modeled as discrete objects. So we model each individual as they're born, as they die, as they obtain disease, and they also have specific properties. And so they start as susceptible, they progress to latent infection at some kind of random rate. They then progress to a pre-symptomatic, where they state where they contribute infection to the population, but they don't seek care yet. Then they go to active infection, smear positive, smear negative, or extrapulmonary, and ideally they're diagnosed and then cured, please. So then we layer on properties to each individual. So one of the properties for this simulation is a residency setting, which we divide into rural, urban non-slum, and urban slum based on UN Habitat data. Please. Each individual can also obtain HIV according to the prevalence of the population, in which case they obtain a CD4 count, which decreases over time, and that's inversely related to their rate of reactivation. And finally, we give each individual a certain level of healthcare access, either high quality access, low quality access, or no access, and that's based on DHS data. So we're making an approximation between antenatal care and general access to healthcare. So the first thing we want to show is that the model recapitulates the demographics of Nigeria. So on the left side, you see the age population in red as its output from the model for the model year 2006. And in the thin gray bars that are next to it on the left side, you see the latest census numbers for Nigeria from 2006. You show that you can see that the model captures the young population of Nigeria, where about 50% of the population is below the age of 20. And on the right-hand side, you see that the model also recapitulates the HIV prevalence in the country, where we calibrated to the 2015 UNAIDS estimate of about 3% HIV prevalence among adults. Please. So we then wanted to show, now that we had the right demographics in the model, what happens when we put TB in, and what sort of prevalence and other epidemiological indicators do we get from the model. So on the left was one of the primary objectives that we wanted to make sure that we hit. So that's the age-band prevalence survey data. And in the red, you see the model, and in the gray next to each of the red bars, you see the age prevalence from the survey. And in particular, the model captures the higher burden in specific ages, mainly the adults 30 to 50. And on the right, you see the model outputs in red against other epidemiological indicators. So we feel like we capture the prevalence by year, as well as the high HIV prevalence among individuals with TB at around 25% currently, as well as mortality by year and other indicators. So now that we have a model that does demographics and captures some basic epidemiology, we then wanted to apply it to the urban-rural setting. So we made a few assumptions. First, as I mentioned, we split the model into 3 groups: urban, urban slum, urban non-slum, and rural. And then we made some assumptions about how much they're mixing. So we assume that mixing between urban and rural areas is fairly minimal, at less than maybe about 5% of, say, like a given day, or you could think of it as a given year. But we then assume that there's a moderate amount of mixing between urban slum and urban non-slum environments, about 20 to 30% of your time. So we're approximating, say, an individual who is living in an urban slum but then goes to work in an urban non-slum and then comes back. We also assume that transmission differs by setting. It's highest in slum, then lower in the non-slum, and finally the lowest in the rural setting. Okay, so here are the results. So the first thing I'm going to show you is the baseline, which is a continuation of the current trends. So on the lower left, I show the case detection rate for the whole population that's simulated, which is about 15%, as I mentioned earlier. And on the right side, you see in the 3 curves the prevalence among the 3 different populations. On the top is the urban slum in yellow, and then in the blue is the urban non-slum, and finally in the red is the rural population. And we wanted to make sure that we captured another one of the key results from the prevalence survey, which is that the prevalence in the urban setting is about 2 times as what it is in the rural setting. And then we then wanted to compare that to an intervention. And just for illustration, we said, well, what if we had an intervention that targeted all slums of the country, and let's say that we increased patient access, or we reduced patient delay by 50% in this population, and then we linked all positive tests to treatment. Please, some animations. Okay. So first thing that happened was that the case detection rate increased in the country from about 15 or 16% to about 22%, and you saw that rather quickly. And then the effect on the prevalence in each of the populations showed, as you might expect, that there was a decrease in the urban slum population's prevalence, but you can barely make out that there's just a little bit of change in the urban non-slum and the rural populations. Yeah, just one second. And then one other thing to note is that the change in the case detection rate was fairly quick in our model. Within a couple of years, you could see that. And then the change in the urban slum prevalence took a longer time. Please show more. Yeah, and about 5 years to reach some sort of stable level. So in conclusion, what I hope I've shown you is that we could create a calibrated model to the 2012 Nigeria prevalence survey that captures a couple of key features: the prevalence by age, the urban-rural difference that's seen in the prevalence survey, as well as other epidemiological indicators like HIV trends. We also hope to show here that this has some demonstrated value for showing the effect of interventions targeting particular at-risk populations. And one of the things that, just to reiterate, what we saw in the model is that you could get a quick change in case detection, but it would take longer to affect some sort of change on prevalence in the slums. And in the future, we hope to apply this to more specific data, using data from our partners at KNCG in Nigeria. And a couple quick acknowledgements. Friends at London School and the Bill and Melinda Gates Foundation for their help with this. And also just some more information on the model. We participate in the TB-MAC consortium of TB models, which had a modeling workshop here. And that work is currently in press. And also our model is freely downloadable at idmod.org. Thank you.
All right, questions from the audience? All right, can you speak to it all? Do you know, based on the model that's been developed thus far, has there been any discussion about possible interventions that might be implemented to show exactly what the model's suggesting about where we can intervene to actually improve case detection?
Right. So our collaborator, Dr. Ogbudebi in Abia State in Nigeria, has a paper where they did exactly that. So they said, let's take all the people who are coming into the clinics for any reason and just screen them for TB. And they found that actually about 6% of those people had TB. Mm-hmm. And so, and that was also, there was also a combined effort with community health workers in that, and just trying to do a combination of things, also screening people with HIV in that study. So I think when we talk about decreasing the time to access, it's going to be a combination of kind of a package of different interventions.
Yes, sir.
I'm someone from the London School of Health. It's very interesting to hear. I just wondered if you'd explored a bit of how the model kind of results depended on your assumptions about this mixing. That's one thing you don't really know, or have any data or something like that.
Yeah, so we haven't done too much of the sensitivity analysis. But yeah, it's.
Can you repeat the question?
Oh yeah, yeah. So Tom asked about have we explored the assumptions about the mixing, and that's something that we're currently doing, because we've made strong assumptions that basically the urban and rural populations don't mix at all, and I think that's true on a short term, but in the long term, there's obviously migration and other things going on. So yeah, it'd be interesting to dig more into that.
I have also a question around the assumptions. It seems from the model that you showed on the, what was it? I think the urban slums, that after increasing the case detection, you see a lowering of the prevalence quite quickly. You say, yeah, it's over years, but it starts quite quickly. And I was wondering, how likely is that the case? Because you're coming from 15% case detection to, well, maximum like a doubling, 30%, 20 or
25%.
And that's the one question, one part of it. But the other part of it is many of the active cases are usually or are infected long ago. So it's not the recent infection only that affect the prevalence. So what are you basing your assumptions on?
Yeah. So one thing I did show is that one thing that is actually pretty interesting is that we get from the model is the prevalence of LTBI infection, and that's actually quite high in the urban slum population at around 65%. And that sort of has a big effect on how quickly you can actually drive down prevalence. And that's something that we're exploring as well. There's not a lot of data on what is the LTBI prevalence in urban situations.
Yes, last question, please.
How did you what are the assumptions around the age specific? Is that just demographic structure, or did you incorporate age specific, like incidence estimates?
Yeah.
Is the incidence flat across the age group?
Yes. Right. So the age is only built into kind of the births and the deaths, but we don't impose age structure on
TV.
Yeah. Exactly.
All right, thank you very much.
Okay, then I would call up Dr. Cavani and to present to us the tuberculosis contact tracing outcomes in London 2012-2014. Before you start, I just want to check one more time if Dr. Hamim from Afghanistan is here. If not,
he's actually here and he's gone again. He did come in, but I think he got used to it, so I don't know if he's going to come back again.
Well, yeah, well, anyway, please do your presentation.
Thank you.
enlighten us.
Hi, I'm Sean. I'm a PhD student at PhD and London School of Fashion. I'm going to tell you about TB contact tracing in London 2012-2015. So, as some of you may be aware, in the start of last year, Public Health England and NHS England published a national strategy in order to combat what were relatively high incidence rates for Western Europe, although they have been declining in recent years. And this strategy proposed 10 evidence-based areas for action, of which one was to ensure comprehensive contact tracing, which is what we've seen on here. So, in order to monitor progress against that strategy, two contact tracing indicators were proposed, which were to monitor the proportion of pulmonary TB cases who had at least one close contact identified, and the second was to monitor the proportion of identified close contacts of pulmonary TB cases that were evaluated for signs of TB and LTBI. So, with that in mind, the aims of my talk today is to firstly to describe the baseline levels of those indicators. And secondly, to identify groups for whom those indicators are better or poorer using multivariable logistic regression. The data set we're using for this is the London TB Register in combination with data collected as part of cohort review. Cohort review, for those who don't know, is a quarterly meeting of nurses and case managers where case management outcomes and contact tracing outcomes are discussed. And as part of that, contact tracing data there's been a wealth of contact tracing data collected. So in some quarters and some parts of London, there's more missing. There's a non-random missingness of data. So I've had to exclude some data from some sectors and some quarters. Come back to the thank you clip. So the first strategy indicator we found in the period 2,716 cases were notified, of whom 2,481 had contacts identified, which is 91%. So, as I mentioned, because of the missing data, the 91% should be representative of London, although the numbers don't represent the total numbers in that period. From those indexes, 11,981 contacts were identified, which is a median of 4 per case, and 10,251 of those, or 86%, were evaluated for signs of TB and LTBI. And that led to 294 cases with active TB, and or 1.8%, and 490 children with latent infection, or 10%. I only know the yield of latent infection amongst children because not all adults are tested for LTBI, only those under 35, and cohort review only records whether the contact was a child or an adult. So if we restrict that analysis to former prisoners, you can see that the first indicator of the proportion identified is just 79% versus 91% overall, and the second indicator is 76% versus 86% overall. So those two indicators are much lower in that particular group. Click. So this table is the results of the logistic regression looking at the odds of an index case having at least one contact identified. And I've just included exposures which have a p-value of less than 0.05 here. So we see that recent migrants relative to long-term migrants, former prisoners, men, and those of Black African ethnicity versus those of Indian ethnicity were less likely to have at least one contact identified. But as were those who index cases who were culture negative or smear negative. And what we did, on the other hand, we saw that next one. We saw that cases who were notified at clinics which had a greater number of social workers or DOT workers were more likely to have at least one contact identified. Click. So this is the same table again, but for the second indicator, whether those contacts were evaluated. we see again that men were contacts of men were less likely to be evaluated after they were identified, as were contacts of white index cases versus contacts of Indian index cases. Click. Contacts notified in a higher notification rate area were also less likely to be evaluated, as were adult contacts and contacts who were screened. Click. Contacts who were screened at a different clinic to their index case. I should also note that none of the social risk factors included in this model, which were homelessness, history of homelessness, prison history, or history of drug use, were significantly associated with whether the contact was evaluated. Click. So, in conclusion, we saw that 91% of contacts of index cases had at least one contact identified. A previous study in North Central London, prior to cohort review and post-cohort review, found that 78% had one or more contacts identified prior to cohort review, and 88% post-cohort review. So it's an increasing trend since that time, and it's comparable to figures from a US study over a 10-year period. We also saw 86% of those contacts were evaluated, which again continued the trend of 74% and 81% pre and post cohort review, and is comparable to the same figures from the US. And these figures will provide an important baseline for monitoring the progress against the England strategy going forward. We also saw contacts of men, amongst other things, contacts of men or those with a prison history, or those screened at a different clinic to their index case, or those screened at a clinic with fewer DOT or social workers, were less likely to be identified or evaluated. And these can provide some information about how we can improve the indicators going forward, and also can help inform risk assessments in future contact investigations. So I'd just like to thank my supervisors, Tom and Amelia, everyone Richard Wright and everyone else in the TB modelling group at LSHTM, Claire Flack at LSHTM, Charlotte Anderson, Lucy Thomas, Helen Maguire, Jackie Carless at PHE, and all the nurses and case managers involved with cohort review. Thanks for listening.
Thank you very much. Room for questions? Yes?
Thanks very much for your very clear presentation. I was wondering, how do you explain that index cases who were culture negative had less often their contacts investigated, given that there's a delay in their culture result being available?
It's a good question. I imagine it might be that no, they're just pulmonary cases. I'm not sure off the top of my head. I had originally thought to myself that it was because they would be less confident that they were less motivation, but I didn't think about the delay.
I mean, of course, it depends what type of culture you're using, but I mean, in general, you would think, I think that's the guidelines in the UK as well, that you will start with contact investigation as soon as possible. Once you have, of course, evidence that someone has, but I assume you don't wait for the culture results to start contact investigation.
No. So it may just be the less strong symptoms and things which lead to less confidence pursuing the contacts. I'm not sure though.
Resources as well.
Huh?
It might be resources as well.
Yeah. Any other questions?
All right. If not, we have a. Okay. That was just a hair swipe. I thought it might be. Sorry. All right. I don't know much about hair swipes, so I'm sorry about that. Well, we have, in American terms, we have a double header here. So, Sean, we're going to ask you to stay up, and we're going to move on to your next presentation here.
Yes, sure.
Sean, whenever you're ready, we'd love to hear about your transmission events revealed in TB contact investigations in London from 2012 to 2015. Thank you.
Thanks. Hello again. So my second talk is along similar lines to the first, and it's using the same data set. Only this time we're looking at pairs in which the contacts had TB. So contact tracing is often thought to have these three aims: to reduce morbidity, to hasten diagnosis, and to reduce transmission from infectious contacts. So with those aims in mind, it's important to know the time that contact tracing takes. However, I don't know of any estimates of this time. So the first aim of this talk is firstly to estimate that time using the interval between the index diagnosis and the contact diagnosis. After interviewing clinics in London, not all of them, but a subset, I found that clinics generally aim to undertake contact tracing in 2 weeks for SMEA positive cases and 6 weeks for other index cases. It would also be important to know the proportion of contacts for whom probable transmission has occurred between index and contact, as this can help indicate the ongoing transmission between contact and index cases. So this value, there's an estimate from the US from about 10 years ago that estimated this to be about 70% of contacts share the same strain as their index case. As I mentioned, I'm using the court review data sets again, and the way this is recorded is each index case has, if the contacts who have TB are listed alongside the index case. So for example, in this diagram where the I indicates an index and C indicates a contact, this index case named 3 contacts. Click. I've removed the so time's going left to right, I should say. I've removed the contacts who were diagnosed prior to the index case, so that they were already known to have TB prior to the contact investigation, and then I look at the time taken between the index diagnosis and the contact diagnosis, and look at the distribution of those times. Click. In order to look at the probable transmission between index and contact, we just click again. We restrict the we restrict the analysis just to pairs of culture positive index cases, so that we know the clustering strain taking data for those pairs. We then count the number who are in a cluster, so that they have indistinguishable mirror NTR strain types, and click and count the ones who have different strain types. Okay, so we looking at the contact tracing time, we found 315 pairs, and the mean time between the index and contact diagnosis was 63 days, and the median 42 days. The chart at the bottom shows the distribution of these times, delineated in red for non-pulmonary index cases and blue for pulmonary index cases, and you can see that about 60% of pulmonary index cases, contact investigations take 2 months or less, and about 50% for non-pulmonary index cases. One other thing I wanted to mention as well, that 42 days is exactly 6 weeks, so that means that in this data set, half of all the contact investigations took less than 6 weeks. Click. Although most of the cases, most of the contact investigations are quite quick, there are a number, a small but not insubstantial number of long investigations. Click. This figure shows the odds ratios for contact investigations being less than 2 months. So, we can see that UK-born contacts and recent migrants, related to long-term migrants, are both more likely to have shorter contact investigations, as are children under 15 years old. None of the included social risk factors listed here were associated with shorter or longer contact investigations, although a history of imprisonment was close. Okay, onto probable transmission. We found 84 culture positive pairs. Exactly 2/3 of these had matching strain codes indicating probable transmission, and so obviously 1/3 had different strain types, meaning unlikely transmission. Click. So this is looking at which subgroups are associated with probable transmission. So the top two are not significant, but pulmonary index cases were more likely to have pairs with pulmonary index cases were more likely to have probable transmission, unsurprisingly, and pairs in which both were non-UK born were less likely to. Although, as I said, both of those are non-significant results. We did see that pairs in which either or both the index and contact had one or more social risk factors, which are the ones I mentioned before: prison history, history of homelessness, history of drug use. They were much more likely to have probable transmission between index and contact, indicating ongoing transmission in those groups. Click. Okay, so in conclusion, we saw that the majority of contact investigations take less than 2 months, but many don't. And the average was about 6 to 8 weeks. Obviously, it's important for contact tracing to achieve its goals. It's important that it happens in a timely manner, as far as possible. We saw that 2/3 of contacts with TB were due to probable recent transmission. So contact tracing is identifying transmission. I should note, I maybe should mention this before. There's no directionality to the transmission from this study, just whether it might have been the contact infecting the index or vice versa. And that proportion was much higher for pairs with social risk factors. And it's similar to the 70% I mentioned at the start of the talk that was found in the US. And I'll put it up, the other side of that is that 1/3 of cases that we find through contact tracing are not due to transmission, which indicates that contacts have a high background risk irrespective of whether transmission is taking place. Some limitations of the study was the relatively small data set, particularly for the transmission results. The record linkage of the clustering data and the LTBR was done probabilistically, so there's potential for errors there. And the strain typing method used may diagnose transmission or matching strain types when they aren't matching. It's just the resolution of the method used. Click. Acknowledgements. I'd like to acknowledge all the same people as before, and additionally Neil McDonald, who helped me from PhD, who helped me with the clustering data. Thank you.
Questions from the audience?
Did you break down the social risk factors, as they say? Did you break that down more by index versus contact cases, or by different social risk factors?
I'm not sure I understand the question.
Sorry, so you said that where either the index case or the contact had a social risk factor, they were more likely.
Yeah.
Look at that.
Whether it was the index or the contact. Yes. I looked individually, and if it was just index, but there's just too small numbers. That was I imagine if the numbers were larger, it might have been, you would have been able to see something, but the numbers were just too small.
Charlotte Jackson, also at University College London. So, with your case contact pairs, did each case kind of only appear once in your data set? Every case just had the one culture positive contact?
No. One thing I didn't mention was there were 2 groups where the index case had more contacts, more than one contact. Nearly all the pairs were just the index case only appeared once. There were 2 groups where the index case appeared more than once. Where they had more than one contact, rather. So they appeared in more than one pair. And I did a sensitivity analysis. It removed 4 pairs after I removed the latter pair. You see what I mean? And it didn't change the results.
A question faculty.
First, this might be a silly question. How did you define a contact? Was it just purely a household contact, or was it people who they spent time with, and it could be workplace? And then the second question is, what was the time for linkage to care for those that were identified as TB positive contacts?
So, the first question, the contacts were identified as any close contact who had contact equivalent to a household contact. So it included household contacts, but also close family friends or partners who don't have it, that sort of thing. But unlike, probably not workplace contacts, unless they were like very close. The second question, I'm not. What do you mean exactly by linkage?
So when you identified a contact with TB, how much time was? What was the time lapse between when you identified them and when they were actually linked to care and they initiated treatment?
I don't know because we don't know the dates at which they were identified. It's not recorded. I only know when the contact was. I mean, I know when they were likely identified soon after the index case was diagnosed, and then so I think that time span will just be slightly shorter than the what I call the contact tracing time.
Maybe a less specific question: how many contacts actually initiated treatment?
I think all of them more or less. Yeah. I mean, I'm not sure exactly, but I wouldn't think there would be many of them.
One question over here, please.
It just relates to Nick here from PhD. It relates to that. So would you have included contacts in mass screening incidents?
No.
Okay.
No, they were not included here. I stuck to the close and household contacts.
That's good. Thanks.
Rashid Brooks from UCL as well. I was just wondering, from your case, contact pairs, what proportion of those, as in contacts diagnosed with TB, came from extrapulmonary index cases? I just asked because in the UK, the guidance is to not screen contacts of extrapulmonary cases.
Yeah, it's true. Yeah, it's just changed.
Yeah.
So for those who don't know, the guidance was just, until the start of this year, we screened contacts of all index cases, and the guidance has recently changed to just pulmonary index cases. Of the pairs, can't tell you the exact proportion off the top of my head. I think it was about a fifth, but I can give you more detailed information about that if you get my contact details. Of the culture positive pairs, there were not many in there, but that's because it's probably less sensitive.
Yeah, it'd be useful to know cases overall, regardless.
Yeah.
Tori from CDC Atlanta. I have a question about the restriction for culture positivity in the contact. So how many pairs did you have that didn't have a culture confirmation among the contacts, specifically with our understanding that kids are less likely to be culture positive and also more likely to probably be infected by a household member? How do you think that might have influenced your results?
So I'm not sure the exact proportion off the top of my head that had an unknown culture. I can
unknown or negative, I mean. But activities in a home without culture.
So about a quarter of the only about a quarter of the pairs both were culture positive. I'm not sure what proportion of contacts off the top of my head. I can't remember. Get on the extra slide, but I can tell you the contact now.
Thank you, Sean.
Thanks.
All right, well, thank you, everyone. I want to give a special thanks. I think it was a monumental achievement that all of our speakers were very respectful of one another and all completed their presentations in a lot of time. And I hope you all appreciate how difficult that is to put together an 8-minute presentation. So thank you to you all. And I hope everyone can appreciate that. I think all these talks highlighted different strategies for reaching groups that are not traditionally reached by our facility-based services, and seeing that when we go and look in these populations, we certainly find more TB, but yet we still have to find different and more innovative and higher yield strategies so we can further and better serve these populations. So I thank you all. We have a few additional minutes. If everybody wants to stick around and talk with any of the presenters, I'd ask if they stay up here for a few moments, and Thank you very much for coming to the session.